Hello, hello, hello. Greetings, good afternoon, good morning, good evening. Thank you for joining the International Council of Psychologists. Welcome. My name is Dr. Dominique Eugène. Today, we are joined by a fabulous team of speakers as we enter our third health series conversation. We will be exploring some of our best thoughts about what is going on around the world about global brain health through the Global Brain Health Institute. We'll be discussing the neurological and neuropsychological health services in vulnerable population in Latin America. We'll be joined by Dr. Lucia Petiera and Dr. Lucia Crivegli. Hopefully I pronounced that correctly. Sorry if I butchered your name. Our moderator today will be Dr. Swati Pashpai. So we're so excited for you to join us. But before we get started, we want to share some information about the International Council of Psychologists. Please note that we will be having our ICP Day 2024 on December 10th at 10:30 Eastern Daylight Time. We're not sure if the time will be changed at that point. So just be mindful that we will have our online conference on December 10th. Also, please note that we will have our annual ICP conference in 2025 in Rotterdam, Netherlands, on April 3rd through 5th. Please, 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 if you haven't already done so, make sure you consider submitting an abstract for presentation. The deadline for presentation abstracts will be on October 1st. So we welcome anybody who's interested in providing a workshop, and we look forward to seeing you in either online in December or in Rotterdam in April 2025. Also keep in mind that for this webinar, you can ask questions or either in the QA chat format or in the chat format. We have the QA section, we also have the chat format. We will do our best to make sure that we're keeping our eyes open and peeled for any questions that come through. Anybody who is interested, certificates of attendance will be sent automatically to all who attend for at least 40 minutes. If your name is, the name that you have listed for this webinar is the name that will be printed out for the certificate. There's no need to be worried about it. We will do our best to send it out to you. Make sure that your name is the correct name that's listed for attending this, and we'll be able to help you out as best as we can. But it does take a couple of weeks, so if you don't see it right away, please, it's okay. We will do our best to get it to you as soon as we can. So without further ado, I will pass it over to Dr. Swati Pashpai, who will introduce our speaker lineup for you today. We'll see you again later. Thank you.
Thank you, Dr. Eugene, for such a warm welcome and warm morning wishes. So I welcome Dr. Lucia Pertiara and Dr. Lucia Crivelli. Please, my apologies if I've not taken the right pronunciation. So I really welcome you both and a heartfelt welcome to you of accepting this invitation and sharing your valuable work over here. So to introduce Dr. Lucia Pertiara, she is a neurologist and she received her medical degree from the University of Buenos Aires in Argentina. She did her residency training in neurology at FLENI and afterwards completed a fellowship in cognitive neurology at FLENI's Memory Clinic. Since 2017, she's co-founded the Argentinian Initiative for the Study of Down Syndrome and Alzheimer's Disease, which is an observational research study of aging adults with Down syndrome. And thereafter, she was a very bright fellow of Global Brain Health Institute from 2023 to 24. The next is Dr. Lucia Crivelli. She is a neuropsychologist by profession, and she leads the neuropsychology department at FLENI in Buenos Aires, Argentina, where her team is committed to both research and clinical practice. She also teaches as an associate professor of neuropsychology at Maimondes University and is engaged in research with CONICET in Argentina. Her work is primarily centered on identifying early methods to detect and prevent cognitive decline and dementia with a special focus on developing countries. Dr. Crivelli plays a key role in the LATAM Fingers project as well, which is a major initiative in Latin America aimed at dementia prevention. Her efforts in the project involve collaborating with leading experts and institutions across 12 countries in the region, contributing to the development of this groundbreaking lifestyle intervention. So I welcome you both, and without further ado, I hand over to you and to start your enlightening conversation and let Agnew talk. So over to you.
Well, good morning, good afternoon, good evening, depending on wherever you are in the world. Thank you very much for such a kind introduction, Swati. It's a pleasure, it's my pleasure to be here and to share with you a little bit of what we do in this southern part of the globe and of my particular work around Down syndrome, as Swati said, is one of my main areas of work and research. So I would like to start with a brief introduction about Argentina, as I'm not sure, I know that our audience is quite heterogeneous, so I would like to start pointing where Argentina is in the world. It's in the southern tip of the South American continent. We are quite a big country. We are the 8th largest country in the world. We have quite a heterogeneous geography. We have plains, we have mountains, we have a long shore, and we also have the Andes Mountains on the west. So we are around 46 million people, according to the last population census from 2022. We are a federal presidential constitutional republic, and according to our economy, we are the 3rd largest economy in Latin America, just after Mexico and Brazil. Our official religion is Christianity, and our official language is Spanish, which is widely spoken in the whole Latin America. So that's something that is quite particular to and specific to Latin American countries. I wanted to say a few words about the population, and I think that this is something that also extends to other Latin American countries, and I think that that's why it's quite interesting, and it's going to be picked up later by Lucia's presentation. I think that it's important to point out how population in our country, and I think that also in most of Latin American countries, have changed in the last century. On the left hand of our screen, we have the pyramid, the population pyramid or age-sex pyramid that illustrates the structure of age and sex of our population. A little bit more than a century ago, we had this expanding population pyramid, which shows a very wide bottom and a quite narrow tip, which represents a high birth rate and also a quite high mortality rate. With this balance, usually these populations are expanding because of the high natality of the population. In the last census, we have a quite different population structure pyramid in which we see that the birth rate has reduced and therefore the bottom of the pyramid has narrowed. And as well as that, also the life expectancy has also increased and the mortality has dropped, reaching to a more stationary population. And in the last years, with the constriction of the base showing a reduced birth rate, our population is going to probably tend to more of a declining population and probably a pattern of aging population in our country, which of course raises the concern of a high dependency index and especially consider the dementia risk our population is facing. So I think that this is something interesting in terms of demographics in our country to keep in mind when we take into account clinical and neurological and brain health issues. So this is how our population is looking now and how it looked a century ago. A few words about our health system. As in many other countries in the world, we have a partition system, I could say. We have 3 subsystems: the public sector, the social security sector, and the private sector. The public sector is the one that brings universal coverage to everybody standing on Argentinian ground. This is stated in our constitution that anybody who stands on Argentinian ground has access to public health services. And it's financed mainly by taxes and, of course, by payments made by beneficiaries of the other two subsystems which use these public healthcare facilities. The social security sector is the one that provides health care to the formal economy workers and their families. It operates through contracts with private providers and is financed with payroll contributions from employers and employees. And finally, the private sector offers service to individuals, to social security beneficiaries, and all those with a private health insurance. This is financed mostly through premiums paid by families and or employers. To give you the possibility to place yourself from where are we talking about, Pleni, our institution, which is a neurological and neurochirurgical institution, which provides healthcare, education, and also does research, works with the social security sector and the private sector. So the system is quite overlapping, as our institution makes an example of. And sometimes our health system can be quite inefficient because of all this overlapping. So regarding dementia, taking into account what we have already said, I would like to mention that we have no specific national plan on dementia. Instead, we have, as a federal republic, we have laws from different provinces, especially, in fact, there are only 10 of the 24 provinces that compose the Argentinian Republic, which have specific laws regarding dementia. And well, we have a mandatory health coverage plan, which means that there are certain services and certain drugs that are mandatorily covered by any of the subsystems in which people get their healthcare from, but we don't have a specific national plan, and I think that this is something we are lacking and we should work on very soon. So after this short background introduction, I wanted to go and dive a little bit into Down syndrome and Alzheimer's disease, which have been my topic of work and research in the last years. I'm not sure how familiar you are with the relationship between Down syndrome and Alzheimer's disease, so I prepared a short introduction about both. Down syndrome is the most frequent cause of genetic, developmental, and intellectual disability. Down syndrome is as frequent as about 1 in 800 live births, so it's quite frequent. And as I said, it's the most frequent cause of genetic, developmental, and intellectual disability. The thing about Down syndrome is that life expectancy has grown dramatically in the last decades. Nowadays, it reaches 63 years of age. This is quite close to the life expectancy of the general population. And it's particularly interesting considering that in the 80s, the life expectancy of people with Down syndrome only reached the second or third decade of life. This was due to the congenital heart defects that really affect this population, but fortunately, in the last decades, advances have been made, and in terms of cardiological surgery and heart surgery, in fact, this has improved dramatically, leading to this high life expectancy. Of course, certain social aspects about inclusion and cultural aspects of how intellectual disability and developmental disability as a whole is considered in society, but the main reason of this extension of life expectancy resides in heart surgery advancements. So the thing is that with this aging of the Down syndrome of the population with Down syndrome, we have come to know that there are many diseases that are quite frequent in this population, and of particular interest is Alzheimer's disease. In fact, the lifetime risk of Alzheimer's disease in people with Down syndrome is higher than 90%, and the age of onset is earlier than in the general population. In fact, if you want to see this graphically, you can take a look at the figure on the right-hand side of the screen, which is taken from a publication from Juan Fortea, leader of a group, one of the biggest cohorts and a leading group studying dementia in the context of Down syndrome. based at Barcelona in Spain. And this is taken from an article he published in The Lancet Neurology in 2020. And here it's represented the prevalence of asymptomatic individuals, prodromal dementia, and established dementia cases of people with Down syndrome according to age. So prevalence against age. And as you can clearly see, up to 40 years of age, everybody is asymptomatic. But from 40 years of age on, you can see how the prevalence of prodromal and established dementia raises dramatically, reaching almost a 90 or 100% of prevalence after 60 years of age. So it's clear that this is a significant problem in this population, that it's very frequent. And in fact, this is why it is considered a genetic form of the disease. You will see why this happened in this next slide. As you may be aware, the cause of Down syndrome is the triplication of chromosome 21. This is the karyotype, and the chromosome 21, usually as in every other pair of chromosomes, should have 2 chromosomes. Well, in the case of Down syndrome, the problem is that there are 3 copies of chromosome 21. And the thing is that chromosome 21 holds a quite interesting and special gene, which is the amyloid precursor protein gene. This is the gene that codes for a protein that is located in the membrane of the neurons, and which is the precursor for the amyloid plaques that can appear in the brain in people with Down syndrome. So the thing is that in Down syndrome, there's a gene dose effect in which the APP protein, which is located in the membrane of the neuron, as I said, has a gene dose effect by which it is increased in number. And as we know, the amyloid precursor protein can follow 2 pathways: the non-amyloidogenic pathway, when it's cleaved by the alpha and gamma secretase, and the amyloidogenic pathway, when it's cleaved by a beta secretase and a gamma secretase. The thing is that when we have an overproduction of APP, as it happens when we have triplicated the gene because of the 3 copies of the chromosome, also the amyloidogenic pathway is enhanced, and the amyloid plaque production is as well, leading to the accumulation of amyloid plaques in the brains of people with Down syndrome. And this is why Alzheimer's disease in the context of Down syndrome is considered a genetic form of the disease. So it's not only very frequent and the risk is almost absolute, but also the fact of having dementia increases crude mortality rates about 5 times. This is also demonstrated in a recent publication in JAMA Neurology in 2019. So considering all these, there are a few gaps that I think that I have identified, and I think that many people, fortunately more than I, besides me, have also identified and are working on overcoming. And the first one is that basic and clinical research in Down syndrome-related Alzheimer's disease, this is BSAD, that's how we abbreviate it, is far behind its counterpart in the neurotypical population. At the same time, and directly related to this, there are no disease-modifying nor symptomatic treatments approved for the use in Down syndrome-related Alzheimer's disease at any stage. When I talk about symptomatic treatments, I'm meaning donepezil and memantine, which have been in use for such a long time in the general population. Unfortunately, with donepezil, there are a few more studies, but they're not enough to approve it systematically for the use, even though we do use donepezil. But you probably are aware, and these names sound familiar to you when we talk about disease-modifying treatments. Aducanumab, the first one, lecanemab, and also donanemab are the new drugs, disease-modifying, that have been approved in the United States in the last years, accelerated approvals and all the things we know about them. But the thing is that none of these are approved for the use in Down syndrome. And what is worse, the thing is that no individual with Down syndrome has participated of the clinical trials that led to the approval of these drugs. So we are talking about a population with an absolute risk and no representation in this kind of clinical trials. There's another gap that I think we should also consider, that is that the research cohorts of adults with DS lack diversity. In this table, also from Juan Fortea in the Lancet Neurology from 2021, we have listed some of the international initiatives that study people with Down syndrome. And as you may see, I told you before that in Barcelona, there's the biggest cohort of adults with Down syndrome longitudinal study cohort. The biggest one resides there. There's also one in the UK. There's the European Consortium, which gathers university, clinical, and research centers from 8 European countries. As you may see them, they are all countries from West Europe. And also there's the consortium from the United States, the ABCDS, Alzheimer's Biomarkers Consortium Down Syndrome, which also has centers in the UK, but it's mainly the US. And there's also another one from the US, which is the Lumine consortium cohort. There's one particularly set in order to create and thinking about clinical trials and this gap that I mentioned in the previous slide, that is the trial-ready cohort DS, which gathered, again, centers from Spain, US, and the UK. As you may see, it's quite homogeneous in terms of it reunites what we call the weird population, wide educated in the Western world and from Europe mainly and North America. So what about Down syndrome in Argentina? We don't have specific statistics from health statistics, but indirectly we're able to gather some data, and we can say that there are approximately 4,000 people with DS living in Argentina, from which around a quarter are older than 25 years of age. And why do I use this age? Because it's more or less what we can consider an adult, and we are approaching that age in which there's risk of cognitive decline and Alzheimer's disease. So what we've done is, at Pleni, we started in 2017, what Swati mentioned in the introduction, that is the Argentinian Initiative for the Study of Down Syndrome and Alzheimer's Disease. This is a cohort study, a longitudinal cohort study, in which adults with DS undergo different procedures. The main one is longitudinal clinical neurological assessment, which are done by me and another colleague, and sometimes we also include neuropsychiatric assessment. Fortunately, we have the support of a neuropsychiatrist, as these patients many times have also neuropsychiatric concerns and symptoms that need to be assessed as well, and it really helps in the understanding of what they are really going through and to give them a diagnostic category. Then they all go longitudinal neuropsychological testing. We use the CAMDEX DS, which is a neuropsychological battery adapted for intellectual disability and particularly validated in people with Down syndrome. There's a Spanish validation. We have the first edition and the second one. We are still using the first one, as it is the one that is validated in Spanish. But hopefully we are going to be using the second edition soon. And we also apply supplementary tests in order to complement the testing of executive function and do a deeper assessment of episodic memory. Many of these tests are the ones that are included in the second edition of the CAMDEX. So we are kind of covering it already anyway. We also perform some biochemical studies. This includes genotyping, mainly of ApoE. And we also perform biomarker testing using cerebral brain PET imaging. We use FDG for metabolism as a marker of neurodegeneration, and Pittsburgh compound B for amyloid imaging as an amyloid biomarker. And finally, for the patients who can go through an MRI, we also do structural neuroimaging with MRI. So far, we have had more than 50 pre-screening. We have recruited 22 participants, and due to, well, some of them pass away, as we saw, mortality rates at this age group are quite high, and especially when dementia is present. So nowadays we have only 9 currently active. The pictures I'm sharing with you are from a public lecture we did a few years ago. In this public lecture, we brought people who work with people with Down syndrome, people who train and who organize physical activities. We are with people for people with Down syndrome, and even people from the community with Down syndrome. There are also members of the community also in the audience in this picture, but probably you cannot see. And these are two pictures from our institution. This is the main one, the one at where we work, and this is the other side this is located in the capital city in Buenos Aires, and this is located in the suburbs. It's the rehab center, which is in a very big green space, which is very nice. So to let you know about some of our ongoing projects regarding Down syndrome, well, we are always working in cohort expansion and sustained engagement. As you can imagine, this population is a very vulnerable population, and doing observational studies in these particularly vulnerable people, sometimes it's difficult to keep them and sustain their engagement across time. So this is something we are always working on, and especially when the things that we can offer to them are observational and not really interventional in terms of interventions to improve their quality of life. So this is an ongoing work that is transversal to any stage or any project we start. We are always working on harmonization with international initiatives, with European and US consortiums. And particularly, we have been working in characterizing the Alzheimer's disease presentation in this group. And what we have found is that amnestic impairment is more frequent than we thought. Traditionally, the Alzheimer's presentation or Alzheimer's phenotype in Down syndrome has been proposed to be of a frontal type with this executive impairment and a behavioral syndrome. We have found something quite different, or not exactly different, but that's something that is quite interesting in terms of the amnestic impairment we found was, in fact, more frequent than and prevalent in Alzheimer's disease presentation than we thought. And we also found that BPSD, behavioral and psychological symptoms of dementia, were also quite frequent, especially appearing early in the disease, preceding or accompanying cognitive decline. And as opposed to what we mentioned before, that the traditional phenotype was of a behavioral syndrome, of a frontal syndrome with executive dysfunction and behavioral symptoms, we found that BPSD were not only, in fact, many times they were accompanying executive dysfunction, but not only exclusively associated to it. We found that they were also accompanying amnestic presentations. So at least we have a very small number of participants, as you have already heard, but I think that these findings are quite interesting and kind of suggest that Alzheimer's disease in the context of Down syndrome is not that different from Alzheimer's disease in the general population. And that's why we should think that we can at least try to implement the same interventions that we have done so far in the general population. And well, a little bit about some projects that are quite exciting for us, and we are going to be working on them very soon. In the first place, we are working on the development of a digital cognitive assessment tool for adults with Down syndrome. This is part of a multicentric study, a quite big study, gathering centers from Europe and the US, and probably from Africa as well. This is led by Washington University, and it's going to be a smartphone-based cognitive assessment tool, which instead of providing specific and one-point neuropsychological assessments, this is designed to administer brief cognitive tests at various times during 1 week, and this kind of overcomes many difficulties about retest and reliability and ecological effects and so on. So we are quite excited about this. Then we are also working on a survey about brain health related lifestyles, caregiving experience, and attitude towards clinical research in South Africa and Argentina. This will be done in collaboration with Trinity College Dublin and following some work I've been doing during the fellowship we shared with Swati. And finally, we are also planning to study social connectedness of adults with Down syndrome in the Spanish cohorts and in the Argentinian cohort. We all know that social connectedness is a protective factor against dementia in the general population, but we don't know yet if this is also the case in people with Down syndrome. So that's the purpose of this study, to be able to quantify social connectedness in an objective manner and social networks of people with Down syndrome, in order to, in a future stage, be able to relate this to the risk of Alzheimer's disease. So this is all. Thank you very much for your attention. And I will give the floor to Lucia.
Thank you, Dr. Lucia. It's really interesting.
You're muted.
Yeah, I'm all right now. Thank you, Lucia, for that wonderful presentation. Thank you, Swati, and thank you, Dominique, and the ICP for this invitation to participate in this webinar. My idea today is to present a little bit of what we are doing in Latin America, but first to introduce some of the problematic issues we have in the dementia field in Latin America. So I'll try not to be repetitive. I think Lucia already explained population growth in our region, how it maps what is going on around the world. So I can describe as population is growing and life expectancy increases around the world. The same is going on not only in Argentina, but in Latin America. Population is growing steadily and population is aging steadily. And we can see this in the different pyramids that are turning into squares as people tend to be, we have less births and we have people aging more and more. This is a concern for us because, as you can see in this very nice graph that was published by ADI, but also was again published in the Alzheimer's and Dementia Journal last year, we can see that the projected growth of dementia cases in high-income countries and in low-income countries differs drastically. And this has to do with risk factors for dementia being so high in regions like our own, like Latin America. So what are the risk factors for dementia? We have this very nice 2020 publication by the Lancet Commission, led by Dr. Livingstone, that explained that around 40% of the dementia cases are accounted by modifiable risk factors and are potentially preventable. And these risk factors include risk factors that are can be modified only in early life, risk factors that can be modified in the midlife, and risk factors that can be treated in the late life. So if we see the update of this publication that was published like 2 months or 1 month ago, we can see that early life education has a strong impact worldwide. And in midlife, we have hearing loss, LDL cholesterol, depression, TBI, physical inactivity, diabetes, smoking, hypertension, obesity, and excessive alcohol abuse. And in late life, social isolation, air pollution, and visual loss are very important. This is a very nice study that includes a worldwide meta-analysis. But when we go into what is happening in the different regions, and I will today focus myself in one low and middle income country region, that is Latin America, but we know that there are publications on the region of Asia and on the region including China also. We can see that these potentially modifiable risk factors are higher. They account for even 56% of the dementia cases. And low education takes protagonism here, accounting for 11% of the cases. So this was done by the same Lancet Commission, but including data from the 1066 study. This is a study that is representing Latin America, but is only including 4 countries in Latin America, when we know whether we have more than 15 countries in our region. So this work was followed up by different initiatives in different countries that studied what was going on in their own regions. And so as you can see, for example, in this nice publication by a group from the University of Sao Paulo and Universidad Federal de Minas Gerais in Brazil, we can see how the differences in Brazil are like the potentially risk factors are different. Less education, hypertension, obesity, hearing loss, and physical inactivity take protagonism here. But when we study what is going on, trying to compare the different population groups, we can see that, for example, poor regions and rich regions have a significant different number of potentially modifiable risk factors. 54% of the cases can be prevented in poor region and 49% in the rich regions. And less education, hypertension, and hearing loss are much higher in the poor regions, whilst, curiously, depression takes a lead in the rich regions. But when the investigators compared what was going on according to race and ethnicity, they could see that white people and black people didn't have that much difference in their paths, but education was maybe the component that was separating groups. This same study was also done with the population in Chile. In Chile, potentially modifiable risk factors are only 45%. They are lower than in the complete region. No? But when you look into the composition of the different factors, you can see how men and women have different risk factors for dementia. And there's a 10-point gap, a 10-point difference between men and women. The prevalence of depression and physical inactivity in women in Chile is very high, whereas alcohol excess is higher in men. So this takes us to think and reflect about how we analyze data, how we group a population, how we study dementia cases and risk factors, and how some things can be different in high-income countries and in low-income countries, and why do we need research that is tailored and is designed to tackle and to investigate the things that are important in each of the populations. No? And this brings me to gender inequalities. So this was a study led by Fabiana Silva Ribeiro, who is also a GBHI fellow, and mentored by Anya Leist, and in which I contributed, in which we tried to understand the gender inequalities as contributors to dementia in our region. And what we saw is that in this nice graph, you can see here that you have the risk factors in early life that have to do with genetic conditions, with nutrition, with educational attainment. You have the risk factors in midlife and the risk factors in late life that we've been mentioning. But in pink, you can see to the right, a lot of risk factors that are not specifically accounted for and take place in our population and are explaining a little bit of what we saw in Chile, what is going on with women and our gender roles. So one explanatory model could be that gender roles have to do with what kind of culture you're immersed in. So we can think about collectivist cultures that have more of a patriarchal model in which objectives have to do with the family and have to do with the well-being of everybody. And we can think about also another model that has to do with individual culture. And what we can see is that collectivist culture takes the lead in Latin America. And in our region, what we have is a very high rate of teenage pregnancy. Women become mothers very, very young, and this has to do with low education, with occupational segregation. It's a cause and it's also a consequence. Being low educated leads to having teenage pregnancy rise, but also teenage pregnancy hinders accomplishments in the educational standards, because women who get pregnant between 15 and 19 years old tend not to finish high school because they don't have access to a healthcare system that provides them with the support that they need, being mothers and also taking care of their education. So many times these women who become pregnant very young also take care of their babies, but take over the caregiver role in all of the family. So they are staying at home, they are not getting education, they don't have a job, they take care of their babies, and they take care of the elderly people at home. This is why also women are more exposed to gender-based violence. Women staying at home, being in charge, and being with the burden of all of the family on top are more vulnerable. And we have seen this grow immensely in our region during the COVID-19 pandemic, where people were restricted to their homes. So a very conflictive vicious circle starts to build around teenage pregnancy and around caregiving. So women are getting pregnant very young. They are confined to unemployment. They start to leave high school, not finish their study. They have low education. This leads to poverty and eventually to poor health. If we look at the rates of teenage maternity in our region, the rate exceeds 12% in most of the countries in Latin America. And these rates are very concerning because they are much higher in the lower educated and the poorest regions than in the wealthiest regions. So in this nice publication, you can see how the lower educated, the poorest regions have higher rates of teenage pregnancies. But what is more concerning is that none of them, nor the highest, the richest groups, nor the poorest groups, are improving in the numbers and the rates of teenage pregnancy. So this is a concern that is not getting a solution at the moment. So when we talk about the caregiver role and the access to the healthcare system in Latin America, we can talk about what's going on with public awareness. As public awareness does not grow on dementia, stigma grows because it's very difficult to get a person to go and seek for a diagnosis, as there is no public awareness, as no knowledge about the disease. And this also doesn't contribute to planning public health policies in our region. So as Lucia mentioned, we don't have dementia plans in Argentina, for example. And this makes caregiving even harder. As you don't have a dementia plan for diagnosis, for treatment, you also do not have support for caregivers, and elevated rates of depression, anxiety, and stress start to grow in the caregiver group in our region. Another thing that we should take into account when we talk about low and middle income countries is the rate of women caregivers that we have in the family. As we all know, women are more likely to have dementia, Alzheimer's, than men. 2 out of 3 cases of dementia happen to women, but also caregivers have the same rate. 2 of every 3 caregivers are women. So most of the patients are women, most of the caregivers are women, and we are struggling with these high rates of depression, anxiety, and mental health concerns. So there's something here to be done, and very important for our region. When we look at TBI, traumatic brain injury, the rates in women are much higher than in men when this violence is measured within their homes. So Latin America has a very high prevalence of femicide, with 14 out of the 25 countries in the world with the highest rates being part of Latin America. 80% of the victims that are victims of intimate partner violence are women. And survivors of these attacks many times have physical health problems like TBI, which is an important risk factor for dementia, but also mental health and physical health, general concerns, travel and consequences. So this is another thing that is going on in our region, and we have to try to raise awareness and work on it. So the last part of my presentation, I will very quickly try to explain what I've been working in the last few years. This is the finger project and the finger model. And the idea is to articulate how an RCT can contribute in some way to raising awareness and also to bringing capacity building in a region that is really in need of this. As we all know, dementia can be considered as a result of an accumulation of genetic and environmental factors that contribute to the disease. A publication by Dr. Miyaki Belto, like 10 years ago, found that there was a very strong effect of the intervention for dementia prevention when you intervene non-pharmacologically in 4 or 5 risk factors: healthy nutrition, physical activities, mental stimulation, social activities, cardiovascular control. So this, as you can see in the graph in the left, produced a different longitudinal result for cognitive outcomes for 2 groups, a control group and an intervention group. The Worldwide Fingers Initiative grew enormously during the last years, and we have now 60 countries participating in this initiative. In Latin America, we have the LATAM Fingers Consortium. We are 12 countries, 13 centers participating in the dementia, in the struggle against dementia, trying to implement a multi-domain non-pharmacological protocol. We are recruiting 100 participants from each country, and we are completely funded by the Alzheimer's Association. So it's multi-domain, it's multi-center. Its primary aim was visibility, because at the beginning, this seems such an important and difficult endeavor that we only tried to achieve being able to implement it. But now we have a secondary aim, that is efficacy. And the project, which started as a pilot of 1 year, was extended to a 2 years follow-up. So we have as an inclusion criteria the risk of dementia, mainly by cardiovascular factors and a suboptimal cognitive performance. And then we have a systematic intervention that includes a schematized workup in the gym, nutrition, cognitive stimulation, and health coaching, all of this done in groups for socialization, and a flexible intervention that receives regular health advice. The project is expected to be finished in December 2025. The first groups are already finishing the intervention. And we are building a very big and important database. The database includes the measures taken every 6 months, with an MRI and ApoE status at the beginning and an MRI at the end. And maybe one of the most important things we are accomplishing is this Latin America Biobank, which will host behavioral, sociodemographic, cognitive, MRI, blood and plasma samples for all of the cohort in a longitudinal basis. So this is a very big and important dataset that will be openly available for publications once the trial is and the embargo are over. So what I wanted to make an emphasis on, and I'm running out of time, so I'll try to be make it short, but try to highlight the most important thing, is how we are trying to build capacity with our trial. So when we managed to just do it and go ahead with it, what we did was to try to harmonize the trial and to build capacity in all of the centers. For this, the design includes interventions in 4 main aspects, as I said: nutrition, physical exercise, cognitive rehabilitation, and cardiovascular factors. So what we did was to build up working groups in which 1 member from each country was participating. For example, in the nutritional work group, we had 12 members. It was coordinated by Mexico, but 12 members of nutritionists discussing the mind diet that we would use. And this was done in physical activity, in cognition, and in health monitoring. So we tried to be respectful of the core features that we shared with the original fingers and with the US pointer, which is the North American initiative funded by the Alzheimer's Association. But we tried also to be culturally respectful, to make something that is affordable and feasible eventually as a public health policy. So as you can see, for example, the physical intervention, was done in parks in Mexico and Brazil, but was done in the gym in Uruguay. And this has to do with what is available in each of the region and what is friendly and feasible for the participants in those regions. The same happened with the diet. We couldn't use the Mediterranean diet from the finger trial because it included things that are very expensive or not even available in some countries, like, for example, fish in Bolivia that doesn't have a coastline. So we modified the diet and made the LATAM Mine diet, which is a mixture of the Mediterranean diet, the Dutch diet, and the Latin American idiosyncrasy. And the same with the outcomes. In the outcomes, we worked the executive committee work group, mainly Dr. Monica Yasuda, Dr. Claudia Suamoto, and me, trying to build up a Latin American battery that measured the same constructs as were measured in high-income countries, but that was viable, that was valid in our own region. So we tested the results and we got to these very nice cognitive outcome batteries that can be compared to international standards. So if you want to read about the design of our project, you can check this very nice paper we published with the design and harmonization strategies. And I can show you shortly some results. Here we can see we have a more extensive participation of women than of men. That is what is expected. This is what's going on in most of the non-pharmacological clinical trials. And also it's not so worrisome because it reflects what is going on with prevalence of the disease, no? in a population. We have different levels of education with countries like República Dominicana or Mexico with very low levels of education and others with higher levels of education. And we have a very heterogeneous self-reported ethnicity. And when we look into each country, we can see how the ethnicity is very different from one country to another. And here we go again back to this tailored need of studies. No? Because in Uruguay, most of the population is white, but if you see Dominican Republic, we have a lot of mestizo population and a lot of mulatto population. So there's an imperative regional need for capacity building. When we look at publications in the different journals, we can see how RCTs are much more frequent in the Northern Hemisphere than in the Southern Hemisphere. And this is the same for publications. RCTs and publications have a very low presence in the lower middle income countries. And we look at the papers published in the scientific literature, and although Chile, Brazil, and Uruguay are leading the initiative, when we compare them to what's going on in high income countries, the difference is enormous. So, well, just to make it short, we need capacity building in the region. We need to strengthen the skills and competencies and abilities and build relationships. That is why this seminar is so important, because we need networking. We not only need funding and investment and infrastructure development, we also need education, training, collaboration, and networking between different regions around the world. Thank you.
Thank you so much, Dr. Lucia and Dr. Priya, Dr. Lucia and Dr. Lucia for giving such a wonderful talk, enlightening everyone with the Latin American status of the neuropsych and neurological conditions for people with dementia. So I have a couple of questions. Before I ask, I'm gonna see if there's any questions that's there on the chat. So first question is, from a public health perspective, what should be the most urgent intervention to prevent dementia? Anybody can take this.
I think that I was going to let Lucia answer this because of all the work she has done with LATAM fingers, but I think that it's clear that it's not that different from, according to the concepts we have from the Lancet Commission from 2020 and the updated version from that has recently come out. We know that there are many modifiable risk factors that we can intervene, in which we can intervene. I think that in our country, in our regions, it depends on the specific population. Some part of the population, as Lucia showed, is very similar to to high-income countries, and then there's a very big other group that has a specific needs, and that it's very different, that it's much more, it's very vulnerable. And I think that education is one of the biggest things. And I think that we need to understand brain health and dementia as the consequence of policy in general, not only of cognitive or brain, and of something so specific to the brain, but of the general conditions of living. So it's education, it's physical activity, it's a healthy diet, it's, well, I don't know if you want to add something else, Lucia.
No, I agree completely. The problem is public policy, trying to make public policy a priority in each of our countries. And within that public policy, we can discuss in each region, in each country, what emphasis should we make on education or cardiovascular risk or on sedentarism. But if we don't have that big step marks, like that we do need dementia plans in every country, then we're very far away from our objectives.
And regarding the other question, if there's any global plan, yes, the World Health Organization has a plan which sets different goals to the countries that adhere to it. But the thing is that it's not respected, I would say, or I'm not sure if there's a formal engagement with it, at least from our country.
Yeah, I totally agree. Yes, there are global dementia plans which do exist and given up by WHO, like Global Dementia Observatory. Such kind of document and such kind of guides are existing, but to what level it can be implemented on the different types of countries and the different type of population, that is a major question that comes into picture, that I totally agree. Another question is, has the incidence in the population of dementia increased over time? That is, compared to the societies of 50 to 100 years ago.
Well, of course, yeah, the incidence is rising, especially in low and middle income countries. Of course, when we go so far away in time, we have to understand that the assessment tools and the concept of dementia have been modified in terms of when do we do that. We can provide a diagnosis from an MCI, from a clinical syndrome to a disease. So there have in so many decades, many differences in the assessment, and the conceptualization of dementia has changed. But in general terms, in low and middle income countries, dementia rates are rising, while it's and more steeply than in high income countries, mainly due to these changes in the population structure that we mentioned before.
Yes, so we have a population structure that Lucia described, about people life expectancy increasing and having less births. And we also have risk factors for dementia in the late life, which are a novelty because human being is living longer and longer. So we have more accumulated risk factors for dementia.
I have a couple of questions, but I think due to time frame, I can't ask two, but I can just quickly ask one about the regional disparities that Lucia has mentioned, that 10 out of the 24 provinces in Argentina has a dementia law, a special dementia laws, which can create like kind of an unequal protection or geographical disparities, in terms of non-discrimination under international humanity United Nations law. So is there any particular criteria on the basis of which these laws have been made in those 10 provinces, whether it's because of the urban or the rural, or it's because of the education wise? So is there any particular criteria why only those 10 provinces have a special dementia law and not the other ones? I'm just curious to know about that.
I think it's a very interesting question, the one that you make, but I think that it's not probably that. The thing is that most of the laws regard special interest days dedicated to Alzheimer's disease, so they are very superficial laws. They are not really laws regarding like ruling how caregiving or obliging healthcare providers to deliver certain services. So I'm not sure if I would speak about a regional discrimination. Of course, it's for sure more easier to access medical care in the capital city and in the main cities in the country. But in general terms, and not specifically because of these laws, even in those 10 provinces that have laws, the laws are very superficial about very superficial topics that aren't really game changers, honestly. So I would say that even though there are a few differences, regional differences, all in all, if we have to be practical, there are no significant differences within the country.
Yeah, and maybe another thing that we can comment more widely about the Latin American region is that we have a lot of political instability. So we have different orientations of governments. Governments sometimes last very, very short. So we don't have like stable public policies. And politics need results to be shown in their own period of time. So these things that need investment in which results will be seen a long time forward, maybe are not a priority to the temporal governments.
Absolutely.
Thank you so much for answering this. And I have so many questions from Latin Finger, but I'm definitely going to get back to you, Dr. Crivelli, off this webinar, because it's really interesting to know this Latin Finger and certain work that we have also been doing with the longitudinal aging study of India as well, LASI-DAD. So I'm definitely going to get back to you with a lot of conversation, but I think due to the time constraint, I have to hand over to Dominic. It's really interesting. Really, thank you so much.
Indeed, it was absolutely very interesting, and we appreciate the time that you've taken out to spend this time with us, and to share the wisdom. There's so many things that's going on in the world, so collaboration is important. Like, I have lots of questions as well, but I'm going to be mindful of the time. And again, we welcome everybody who's interested in learning more about ICP to check out our webpage. We appreciate the time that we all have together, and thank you so much for joining us. Please keep in mind the recording of this webinar will be posted on the ICP webpage. Our next webinar will be scheduled for September 27th at 10 a.m. Eastern Standard Time, 4 p.m. Central Time, and that will be the Human Rights and Suicide. Also on October 1st, we will have our last series of the health series, and we'll be discussing disseminating public voice in Africa. So as always, it's a pleasure to have everybody join us. Thank you again to our speakers, and we so look forward to seeing you again. Please join us. Thank you, everybody. Have a good night, good morning, good evening, wherever you are in the world. Bye now.
Bye-bye.